Hello. Hello. Good evening.
Sorry.
Good afternoon.
Good afternoon. How are you?
I'm fine, and you?
Doing well. Yeah.
Okay. Welcome. Welcome to this much anticipated session between the South Africans and the Americans.
Yeah, I'm very excited.
Unfortunately, Lindiwe and Tolakele are unable to connect.
Okay.
I informed them that I'll put them on the speakerphone.
Okay.
They must just phone, and then I'll put them on the speakerphone so that they can hear us. If there's anything we need from them, we can listen in. But they won't be able to talk to us. Okay, can I go right ahead?
Go ahead.
I'm just going to do the opening remarks, which is that I'll just talk briefly about the purpose of this meeting, which is for us to exchange information and then also to learn from each other. Okay.
Okay.
And then you remember in one of our interactions, you asked me about, or we talked about the prevalence of HIV between us, South Africa, and United States. But I won't talk about the whole South Africa. I will speak in general and then refer to my own province, which is the Eastern Cape. Eastern Cape is one of the 9 provinces in South Africa. Then in Eastern Cape, there's many districts. Districts, it's like you do know what is a district in your own country. I am in Nelson Mandela district.
Okay.
I'll tell you that that South Africa has the largest number of people living with HIV worldwide, with an adult HIV prevalence of 17.9%. Eastern Cape, which is one of the 9 provinces, of which I already referred to that, and then I told you that Eastern Cape is one of the provinces that make up South Africa. We have a prevalence rate of 18.7%. So we have 6.6 million people living in the Eastern Cape, but in the whole country, the total population is about 50 million people. Now, if you look at it, if we have a prevalence rate of 18.7 with 6.6 million in the Eastern Cape, that's a lot of people that are living with HIV.
Yeah.
Yeah. What about your own country?
So if we remember, so we didn't have it in percentages, but for the rates, this is per 100,000 people. It was 171.3. So
Okay.
maybe I can see what that calculation turns out to be for you. Sorry about that. So for Minnesota, that's the state we live in, and it is 0.17% of the population. So probably how would that be? So that's the prevalence. So that would be about 1/100th of the percentage of what you have there. Is that right? A calculation? Yeah. So very, very small numbers.
Yeah, a small number of people. I'll gather that.
Yeah.
Okay. If there's nothing you want to say, Halima, we can move on to the case scenario. I've sent you the case scenario from Tolakele. Tolakele sent us the case scenario. So what I'll do is I'll just go through it quickly. It's a 40-year-old female who's known with HIV since the year 2000. History of pulmonary TB in 1999 and in 2016. So she's had recurrence of TB in 1999. She was diagnosed, treated, and then again she had it in 2016. She's unmarried, 9 children with different fathers, abuses alcohol. She has an HIV positive child that was born in 1999, never attended antenatal clinic. and was only diagnosed in the labor ward. So nobody knew. I'm sure she didn't know that she was HIV positive. So she was only diagnosed when she was just about to deliver the baby, right?
Okay.
Then she suffered what is called virological failure due to non-adherence. Now, in South Africa, virological failure simply means that they put you on the first-line treatment. Now, first-line treatment is they put you on tenofovir. You remember you asked me earlier about what is TDF? TDF is tenofovir. They put you, it's a combination, it's one tablet, which comprises tenofovir, emtricitabine, and then efavirenz. So you take one bag. But if you don't comply, in other words, if you don't take it every day, the body, there will be resistance to that medication. It will not work. What will happen is when they check your viral load, the viral load in this country is done every 6 months.
Okay.
When they check your viral load simply means it's the amount of the virus, HIV virus in your body. It's a viral load. Okay, it will be very high because the ARVs, antiretroviral medication, will not be reducing the viral load because of the resistance. Okay, I hope you are with me. You must stop me understanding. Now,
yeah, that makes sense.
Okay, makes sense. Okay, the father of her last two children. Remember, she has 9 children.
Yep.
Now, the father of her last 2 children was diagnosed with HIV in May 2018. Only collected his ARVs once. He was diagnosed in May 2018, so he came to the clinic to pick up the medication only once, and he told the nurses that he will not be taking the medication because, according to him, his girlfriend is not dying of HIV. That is his reason. Now, what the clinic did, which did the test on him, was they asked a test on him, the boyfriend, as well as this patient we're talking about. They sent an NGO, and the NGO is a non-governmental organization, staff member to visit the home of this patient. And they told her, we wanted to know, why are you not taking your medication? Or why are you not coming to the clinic to come and fetch your medication? According to the report, she did not have the money to go to the clinic at the time, and she didn't have the money to buy washing powder to wash her clothes, and she also admitted to be abusing alcohol and not taking the ARVs, antiretroviral medication, when she's drunk. Okay. Now, the doctor and one of the nurses in that clinic and the NGO staffer further counseled her on the importance of treatment compliance and heavy alcohol consumption. She stated that she's frustrated. Not only does she does not have money, but her last 3 kids were not getting the social grant. The social grant is the money the government gives to those people who are poor, because at the time she did not have an ID document, as it was with the loan sharks. Because she owned the money. You know, loan sharks, eh?
Yep.
People that will give you money, they'll take your ID document. Now, the NGO assisted her, and I suppose they went to the loan shark and demanded that she be given their ID document, which ultimately they gave it to her, and then she could then go to the social development. That is where they apply for the social grant, and then she got the grant for her other 3 children that were not receiving social grant. Okay. Then after receiving the social grant, the lady, according to the report I received when I was compiling this scenario, this came from Tolakele, is that she is now coming to the clinic on her appointments. She appears clean whenever she visits the clinic, unlike before, when she would come to the clinic appearing unkempt. Okay. But she still struggles with alcohol abuse, but there is some improvement. In other words, she's trying to deal with the alcoholism problem. The NGO is visiting her on twice monthly. Excuse me. Her only child with HIV is not adherent, is still angry with her mother. You remember in 1999, she gave birth to a baby girl. This is the baby girl that was infected with HIV. She's very angry with her because she's of the fact that she passed the HIV on to her. In other words, she was not taking ARVs during pregnancy. It is a mother-to-child transmission of the HIV. But it is an ongoing process in order to counsel her to accept the fact that she's HIV positive. But at this stage, she's still very angry, as you would understand. Okay. Then we'll talk about the treatment options in South Africa and the US. We'll talk about that. Can you tell me, what do the HIV positive patients, what do they receive in terms of treatment? What treatment are they put on? Do you know?
I guess we didn't look too in depth in that because we didn't really think about that need. I know that, I tried looking into it at one point, but I was sort of struggling. We did find that if a patient is at high risk for contracting HIV or AIDS, they do have like a prophylactic medication, or they give the HIV or AIDS medication to them prophylactically to help prevent or reduce their risk of developing the infection. Otherwise, I don't know. There's so much information.
Yeah, I think they just do the usual treatment for HIV AIDS.
Yeah.
Like from what I have heard, it's just the usual treatment. They don't do anything like
I do know, so I've taken care of one patient with HIV this past summer, and she had 3 medications that she was given for HIV AIDS. So they were 3 separate pills. I would wonder if maybe they're the same medications that you give in just a one pill form. I'm not sure though. But she was struggling with being compliant because she had forgotten to bring enough on some sort of vacation. And I guess the medications make her very sick if she has been off of them for a while. Is that the case with patients over there with the medications you give?
Yes. Firstly, let me just respond to the one question that you asked us. About the availability of medication in South Africa, ARVs. Antiretroviral medication is freely available in this country. The patients don't pay money when they get to our primary healthcare clinics. However, the challenge with the patients is when they are living far from the clinics, if they have a problem with the transport. Can you remember the patient that we talked about? They had a problem in getting to the clinic because of transport problems. So she couldn't access the treatment because of living too far from the clinic and unable to pay for the transport. In this country, we are using the national consolidated guidelines for the prevention of mother-to-child transmission of HIV. Just have a look at this. Can you all see this?
Yep.
Yeah.
Okay. This is what we use as a guideline for managing HIV for adults, pregnant women and children. Okay. Now, in South Africa, you have what they call 3 regimens of HIV. The first regimen is what we referred earlier. If you can you all see this? Can you see this?
Oh yeah. Can you bring it up
a bit?
A little bit higher?
A bit higher? Can you see it?
Closer.
Yeah, like that.
Yes.
Thank you.
Okay. All right. Okay. This is, as it says here, what to start at first-line regimen for adolescents who are 15 years and adults. This is a first-line regimen, okay? The patients are started on tenofovir, which is TDF. TDF stands for tenofovir. And then 3TC, which lamivudine, which is called lamivudine, or FTC. FTC is what they call emtricitabine, okay?
Okay.
And then a preference. But it is a combination. They get one tablet, which has a combination of all these 3 drugs.
Oh.
Right?
Okay.
That's a first-line regimen. Excuse me. And then if the patient is not is failing on this regimen, they'll put them on regimen 2 and then regimen 3. Now, regimen 1, you will find in primary clinics, they will give the patients who are HIV positive, starting them on treatment. They'll put them on this regimen. If they need to be switched to regimen 2, it would have been because of the failure on this regimen.
Okay.
So regimen 1 is an initial regimen. Regimen 2 is if the patient is failing on regimen 2. You remember that case scenario? That lady was failing on regimen 1.
Mm-hmm.
Because of non-adherence, not taking ARVs every day. So she had to be put on regimen 2. And even on regimen 2, I think she was struggling with a viral load because of not taking her medication regularly. Okay. So this is what we are using, but before even though we are providing this antiretroviral treatment, we are also screening the patient in totality. We will check them for HIV. Sorry, for TB. We'll screen them for TB.
Okay.
If they have TB symptoms, we will test them for TB. We take the sputum sample. We will check what they call a gene expert. Gene expert, it will tell us that the patient has got a mycobacterium. Then they will be put on anti-TB medication.
Okay.
They will also be screened for sexually transmissible infections besides HIV, right? If they have any signs of their sexually transmissible infections, they will also be treated. So it's not that we don't only focus on the HIV, we also focus on the total human being. And then if they have other problems like social problems, we will get the social workers involved. If they have depression because of course showing signs of any psychosocial problem, they will be referred to our psychologist as well.
Mm-hmm.
Okay.
Yes.
Or a social worker. So it's a multidisciplinary team that treats people living with HIV.
Okay.
Okay. Are you clear about what we talked about?
Yep.
Yeah, I think so. Yeah. It seems that our services are very similar in some ways. I think that the RAAN, or the Rural AIDS Action Network, does a lot of those similar things of getting people with AIDS or HIV connected where they're needing assistance, whether psychologically or otherwise, and they provide actually free
rides,
free transportation for all HIV visits, as well as all other healthcare things, and then for mental health or picking up medications from the pharmacy. They allow for 2 or more visits, or up to 2 visits a month for each of those things. So you can have 2 pharmacy visits, 2 mental health visits, 2, I can't remember the other ones.
Yeah. And then I think the only thing different with what you said and what we do here is the TB screening. Because over here, there's not a lot of TB cases. So we don't usually screen, I don't think HIV, like from what we read, HIV, people with HIV are not usually screened for TB, but they're screened for other sexually transmitted diseases. Like one of the most one they test for is Hep C, hepatitis C. So it's similar to what you're saying.
Okay. Also, I think I must also point out that when the patients are diagnosed with HIV, they do take bloods. Either than taking bloods for viral load, they will take bloods for what they call CD4 count. I'm sure you do know what CD4 count is.
Yeah,
CD4,
I think so.
It's for the T cells.
Oh yeah, yes, of course, yeah. Just took me a moment.
Right. We do test them just to see how much is the CD4 count. Now, previously, the government policy was that before a patient is started on ARVs, they will wait until they have a CD4 count of 500, right?
Mm-hmm.
It started with it was initially, I think it was 250, and then it was 500, and then ultimately there was a decision, a policy of the government that says it is called UTT, Universal Testing and Treatment. So now the CD4 count is not a criteria before you are initiated on or started on ARVs. Okay. Yeah. So the client can be, but we always assess the readiness. It doesn't mean that if you are not ready for your ARVs today, I'm not going to force it on you. We will still need to counsel you until you are ready for the ARVs. If the patient shows signs, we also test them for syphilis. Okay, we do test them for syphilis. It's called RPR. They get tested for syphilis. And then if they have signs of hepatitis, also they will be tested for hepatitis. To screen them. It's called hepatitis screening. So all those, ours is, especially at primary healthcare, we look at the individual in totality and see what, based on the clinical examination, what are the tests that are appropriate for them.
Yeah.
Okay.
Yeah, so generally the healthcare here, that's what we do, like generally, forget the fact that it is HIV. When a patient comes in, we look at the patient as a whole and try to treat the patient and everything. So like similar, like so.
I think, it's very similar. You know, maybe some of the tests that that you would test for along with HIV, depending on what signs they're showing. You know, if they were showing signs of other things, we may test for those, but other things some of the tests that you do, we may not do, as Halima said, due to, you know, the prevalence of those conditions within our area. Maybe it's not as necessary to test for those. One thing I was just actually thinking about is, so you were saying that this lady in the case scenario, that she had not been to an antenatal clinic. So are you saying like for the entirety of her pregnancy she didn't go?
For entirety of her pregnancy, she did not go. Now, antenatal clinic services are free of charge. The patients don't have to pay. But you do find patients who don't come. We, at our clinics, we always tell women that they need to come to the clinic before they're 20 weeks, pregnant. When they come to the clinic, the antenatal clinic, they get tested for HIV. If unfortunately they're HIV positive, they will be put on ARVs. It's called prevention of mother-to-child transmission. I'm sure you've got a similar program there.
Yes, yeah.
We will also link them to Mom Connect. Mom Connect is the Department of Health's initiative, which is they register their cell phone and then they give them SMS. They give them SMS in every trimester of the pregnancy. Now, in the first trimester, they'll explain to them what to expect. In the second trimester, they explain to them what to expect. In the third trimester, up to the day they deliver. And when they do deliver the baby, they also inform them about what can happen in that period. Now, what is also important for these women is that also we assess them for depression. Because remember, depression is also a problem in pregnancy. Especially what can happen, they can have what they call postnatal depression. So if the nurses pick up signs of depression during pregnancy, they'll have to counsel them and refer them to the psychologist. The last thing you need is a mother that will strangle their baby to death, you know. They are so stressed. Okay. And even beyond that, they will educate them on nutrition, on the diet, and what to eat. They'll provide them with nutritional supplements. Normally, we give in this country we give ferrous sulfate. I don't know in your country we give ferrous sulfate, and we give folic acid. Right.
We often we have a prenatal vitamin, is what they call it here, and it has those like the ferrous sulfate and the folic acid, as well as other nutrients, like iron.
And then we also have an organization that is almost like the Mom Connects that you just mentioned. We call it WIC, is Women, Infants, and Children. So they do basically what you just said, and within the organization, and something else is, but you have to register, like you said, the mothers have to register in this organization. And one other thing, I don't know if they do it in Mom Connect, is but they actually provide food. Like you get meal tickets and you can go to stores that work with those organizations and actually get groceries for yourself and your baby.
Mm-hmm. And this is specifically for people who are financially at risk or low income, as well as who are nutritionally at risk in some way. Whether the mother is pregnant and has a low iron or hemoglobin, or just can show that she does not have the resources to
take care of herself and her baby.
Mm-hmm.
So and they do the text message also, where throughout the pregnancy they send you text, and once you're done, like I think up to a year or two after birth, they keep sending you the text and contacting you, and they have the hotline that you can call if you have questions also.
I know for remembering sorry, my words. So if a mother is not breastfeeding her baby, she can receive nutrition for herself for up to 6 months after the baby is born. And then if she is breastfeeding, then up to 1 year after the baby is born. And then that baby can receive nutritional support up to 5 years of age. So.
Okay. So you do have a Mom Connect, but you're calling it differently. Okay.
Yes.
Now, even in our country, if the pregnant woman is found to be poor, they are going to be referred to the dietitian as well as a social worker. The dietitian will assist them in terms of nutritional, providing them or linking them to an organization that can provide food parcels for them. But once they give birth, and if they are poor, they will apply, or they can apply for a social grant. We do get some money for the fact that they have a child and they are poor. Okay,
Mm-hmm.
So we do have those programs, and we do have our NGOs, non-governmental organizations that come and assist these women. But the only thing that we use a means test. A means test to make sure that it's someone that's poor, so that we don't give it to everyone, because there's a criteria. The person must be unemployed, and they must be not, having support, maybe having a family that is middle class or wealthy. So they are using the means test to make sure that it's only those who qualify that can be put on the program.
Yeah, we have similar criteria here also. It's not everyone that gets it. You have to meet a certain criteria, not necessarily unemployed, but you have to earn up to a certain
per
amount.
Number of people in your household, there are certain income limitations that you must meet to be able to qualify for the program. That makes sense. So I think for a one-person household, it's $14,000 a year in US dollars. And then it goes up depending on the number of people in your household, whether you qualify for the program or not.
Well, in this country, they get about 350 Rand, which works out to about $30 US, not that much.
Mm-hmm.
It's not that much, I know, but at least it's better than not getting anything. They can still buy some food, and they can also get food parcels in order to support them a bit more.
Mm-hmm.
Right?
And similarly, I'm not sure. So for us, it depends on their income, how much they are able to receive in grants or in financial support for their family. So, a person who makes a little bit higher income but still qualifies for the program will get less money than someone who is lower income, has a lower income, if that makes sense. So
in other words, there's a sliding scale. If you earn so much money, you'll get so much money.
Yes.
Okay. Well, in our country, there's no sliding scale. Every pregnant woman that has, that is poor or gives birth, they get $30 equivalent, 30 US. That's about 350 rand. Okay, let us just go back a bit. I wanted to show you, this is a research that was done. It was done by the HSRC, Human Science Research Council, Johns Hopkins University, and it was funded by the United States as well, this research that was done. It is done on female sex workers, okay?
Okay.
The results are as follows. I'm not going to talk about all of them. I'll just highlight just only the one. If you can look on the top, it says HIV and syphilis prevalence. Can you all see that?
Yep.
Syphilis prevalence.
Yeah, I can see it. Yep.
Is it okay? Right. If you look at if you look at this research, HIV prevalence, the percentage was 63.7%. In other words, the participants of this research were 410 sex workers. Right?
Okay.
In your country, you call them prostitutes, but in this country, we call them sex workers.
Mm-hmm.
Out of 410 that were researched, 261 were found to be HIV positive.
Okay, so over half?
Over half.
Yeah, that's just over half, 63.7%. I wanted just to show to you that HIV is a burden, one of our burden, it's a burden of disease in this country. Okay. Mm-hmm. And just also to indicate to you, mother and child transmission in this country, the Department of Health is doing all they can to prevent it. I think we are getting better in preventing it. Only if the women come before 20 weeks. And even if they come a bit later after 20 weeks, if they do finally come to the clinic, they are given the ARVs so that they don't infect the growing fetus or the growing baby, right? Okay. Then let me just see if I've covered everything. Just before we get to the summary or the reflections, is there anything else that you can remember that we must just maybe talk about briefly?
I was sort of thinking, Corleen, so I think I remember this, but I don't want to assume, and I think this is what I'm understanding, but if you go to the antenatal clinic, you will be tested for HIV. Is that correct? Yes. Okay. So it's very similar here, and yes, we also give treatment. Outside of poverty, are there any other risks for a mother not coming into the clinic? For example, here, if a woman is dependent on certain drugs, she may be afraid to come to the clinic because she's afraid that they will take her baby away, when in reality, if she were to have come, there's potential that they would definitely try and help her stop so that way she can keep her baby and to help her as well. And as we know, there's a lot higher risk of a person with a drug addiction to have HIV or AIDS due to used or shared needles. So that's a population, I guess, here in the U.S. That they're higher risk of transmitting HIV to their babies due to not coming into the clinic.
Yeah. Okay. If you remember the scenario, it's the same. What you are explaining. It's also covered in that scenario. You remember that he was was using alcohol,
mm-hmm.
and has 9 children from different fathers, and one of them is HIV positive. And up to now, she still is abusing alcohol.
Okay.
In this country, if the social workers, if there is a what they call a Child Care Act. Now, a Child Care Act allows the social worker or the government to remove any children or any child that is found to be in a home where they are not looked after. Right?
Okay.
The child is taken to a foster parent. Foster parent will get some money from the government in order to support that child while they are busy counseling the mother to see if maybe her behavior can be modified, right? Mm-hmm. Because the idea is not to remove any child from their parent, but if the parent is unable to look after them, obviously the government must step in and remove that child. If the child is abused, if that child is not given food, is not sent to school, that means that the parent is not fulfilling their obligations.
Yeah.
So we do have those programs, but of course we will start first with counseling and counseling. If counseling fails, then it means, and the child's life is in danger, the child will be removed from that family and taken to a family that can look after them.
Yeah.
Okay.
Our child protective service here is basically, you just explained it. It's like you basically just said the same thing. So
yeah, so it's very, very similar. They only take away in to help the child and to help the mother, and with the intent, if they take away a child, it's with the intentions of hopefully being able to bring the child and the mother back together eventually. But we have to address the necessary problems before that can happen.
A question I have though, in the scenario, the mom is an alcoholic, like you said. So what type of programs are like available over there to help with like her alcohol problem, or do you just let her like try to deal with it herself and just cancel her?
We do have non-governmental organizations that are involved in counseling people that have problems with alcohol. There's an organization called AA, Alcoholics Anonymous. Okay. There is an organization called SANCA, South African National Council on, I think it's SANCA on alcohol and substance abuse. Mm-hmm. They do have programs which are assisting people that have alcoholism problem or that they're having problems with drugs. But with everything, someone must be willing to be assisted. Yeah. If they're not willing to be assisted, then the government will have to find other means. If there are children involved, as I've explained, the children will be removed from that environment because it means that the parents are not fulfilling their obligations. Now, the children won't be taken. If you remember in that scenario, that woman was saying that she does not take the ARVs when she's drunk.
Yes.
There's an element of not being responsible. Now, when Tolakele gave me the scenario, she did say that the NGO, the non-governmental organizations, they do have social workers that get involved in the system. But this lady is improving from what I gathered from Tolakele. She is improving in terms of she's trying to deal with her alcoholism. In other words, the NGO is assisting her and she's also willing to be assisted. The only problem that's still outstanding is her child. Her child is still very angry with her.
Oh, okay.
Right? Mm-hmm. She's not taking the medication, the ARVs, because she's still very angry. But it's, as I've mentioned, it's a process. Adherence in this country, I'm sure in your country is also a problem. It's a long-standing process to get people to adhere to the treatment. ARVs or the journey of HIV is a long journey. Us as healthcare workers, we must not judge. We need to support. If the people default, in other words, they don't take their ARVs, we need to find creative ways of bringing the message across that, look, if you don't take your ARVs, you are going to be sick. But we must say it in such a way that they don't feel that we are judging them. Yes. Right? We mustn't judge them. Because once we judge them, they tend not to want to trust us. And it's important for us to build a trusting relationship. Although we need to be strict, especially in terms of if there are children involved. Right? That is why the children ultimately will be removed if there is no change at all. But it won't be a long period. The social workers are going to monitor the progress. If the parent is not getting better, it means those children will stay longer with the foster parents until she's able to be rehabilitated, from the alcohol abuse or drug abuse.
Okay.
So there's a continuous engagement to assist as much as possible. We don't give up. As healthcare, as nurses, as doctors, and all healthcare workers, we are working. I'm sure it's the same with the US. Yeah. We are doing everything we can to assist. But I'm sure in the US, you don't encounter the problems with adherence in the same, maybe in the same magnitude as we do. Because here, you are not only dealing with non-adherence, sometimes there's a social reason for it. If the woman lives far from the clinic, she will not be able to go to visit the clinic on her appointment dates. Now, you can blame her for that, but you really can't. If she will tell you, I don't have money to get to the clinic, right? Mm-hmm. Right. Or she will tell you that the reason why she couldn't come to the clinic because there was no one to look after the children.
Yep.
Right? Now, the safety of those children is also important to her. If she doesn't have, because you remember when you go by taxi, even you pay for your child. If she only has the money for herself, how is she going to leave the children? How can she leave the children and go to the clinic? Who's going to look after the children? So there's a lot of social issues involved. That is why I'm saying as much as possible, we don't want to blame them. We want to get to the bottom of what is their problem? How can you assist them as much as possible?
Yeah. Okay. I feel like it's very much the same here. So
yeah, I think that we talked about, let me just see if I can just wrap up quickly. We talked about the purpose of the meeting between us. We defined the scenario. I'm just making sure that we're covered everything.
No, you're fine.
We defined the scenario of a patient and a family in crisis of HIV. We talked about holistic assessment of patients and their experiences, as well as signs and symptoms. And signs and symptoms of ARVs vary it depends on what stage the patient is if the patient is in, for example, stage 1 of the HIV, they will not be having any symptoms, right? But as they progress from stage 2, 3, and 4, you will find that they have specific symptoms that will tell you that this patient is stage 2. Right?
Yes.
For instance, if you look at, there is one stage where if you ask them to open the mouth, you will find that on the lips, they will have sores around them, right? And then inside, when you examine, you'll find that they have sores also all over on the tongue or on the palate. So it depends on where they are. Now, these stages are prescribed or suggested by WHO, World Health Organization, right?
Yep.
We talked about the effect of HIV on the family. The effect of HIV on the family is far-reaching. You will find that there's issues around adherence and disclosure.
Yes.
Disclosure is so important in HIV. Because if the patient is living with HIV and they haven't disclosed to anyone, that means they are living with HIV, no one knows. Now, if they suddenly become sick, no one knows what they are sick of. I'm talking about the family. They don't have to disclose to everybody, but at least to have one person that they trust, that they can disclose to in their circle, whether it's a family or whether it's a friend that they can disclose their HIV status to, right? We talked about the available resources and solutions to offer to the family. I think we talked a lot about that. Mm-hmm. And then we talked about the treatment guidelines. I showed you our guidelines, and I'm sure you have guidelines in your own country on how to treat HIV I'm sure you do have them. I told you about the community resources that are available. That's your NGOs, non-governmental organizations, amongst them. Even the families are also an important resource. You'll find that there are families who have everything. They can support, they can provide the money, they can maybe take them to they can maybe drive them to the clinic. So we need to find all the resources around the patient. Right.
Mm-hmm.
Now, if there's anything else, I just want us to talk about, to reflect on about our meeting together. You remember the first time we met with Professor Hans and Mrs. Helen Band? Just to have a little bit of a reflection over that. Over to you.
A reflection over the whole course of everything, or is that what you mean?
Yeah, we can talk about our meeting, WhatsApp, sending out, sending messages, and the fact that we were not sure this day will happen, or anything that you can. I'm not limiting anyone.
Yeah, I mean, I think it has been definitely a process. I've enjoyed it, even though there's been complications at times, but it's very understandable that there are complications.
We're across the Red Sea.
Yeah, we're across in very different countries, and the networking can be an issue, and you guys are in clinic all day, Monday through Friday, and I had those issues about weddings and conferences that I was doing on the weekends that made it difficult to meet. But I think we did a good job of figuring out a way to communicate different things and learn more about each other's countries and how we approach HIV/AIDS care, and how the people in our different countries are affected by their diagnoses, or what puts them more at risk. I think that it's cool that we can also go back, and look at those messages or listen to them and recall some of these things. And I know it's been a difficult road, but I hope we can stay in contact a little bit.
So that when we visit South Africa, you can show us around.
Right. For me, let me tell you, it's my first time, talking to people using this medium, Google Zoom. It's my first time. I've never done it before. We always use the medium of WhatsApp. Okay, that is the first time for me. That is the one challenge. The other challenge is, of course, having this meeting and just talking, seeing each other, besides using the WhatsApp. And learning from you how you do things over there, and I'm also, when I listen to your prevalence, and I was just thinking to myself, if only we can get to where you are.
Yeah.
And we must do our level best to get there, in terms of telling those people who are not infected that stay uninfected from HIV. We are spreading all the messages that people must use condoms, right? They must use condoms. Yep. They must use protection. And even if they are both HIV positive, it doesn't mean that they mustn't use protection, right? Because there's different strains of the virus. There's HIV-1 and there's HIV-2. And we need to look at deal with HIV as not as an individual disease. It's a societal disease, yes. Right? Because it affects not only the individual, it affects their children. It affects, if it's a husband, it affects the wife. If it's a wife, it affects the husband and the child. So it is a disease where everybody needs to be involved. There's a saying that you are either infected or you are affected by HIV. If you are not infected, you are affected. In other words, you can be living with HIV, or you can be having a family member or a friend who's HIV positive. So it was my first time, as you rightly pointed out, that I hope that there will be more interactions of this nature. Mm-hmm. Maybe we'll visit each other. I don't know the possibility of that. Or we can continue to communicate. It's unfortunate that my two colleagues, Tolakele and Lindiwe, were not able to be part of this.
Yeah.
And I wish once again to thank Professor Hans and Mrs. Band, our lecturer, for having created this opportunity for us to be able to meet. As I've indicated, it's the first time for me having this interaction between South Africa and the US. It's really for me wonderful, and I'm looking forward to more engagements of this nature in the future.
Yes.
It's the first time for us also, so it was a learning experience.
Mm-hmm. But yeah, I appreciate that we've been able to do this, and appreciate the teamwork, or the collaboration that you guys had with us, and us with you, or whatever, together. So yeah. Thank you so much for meeting with us today.
Yeah, thank you.
Tolokele and Lindiwe, that we miss seeing them, but we very much understand their circumstances. And hopefully we'll find an opportunity.
And we love it. There's certain parts of this country where you struggle a lot with the signal.
Oh yeah.
Yeah. I understand that. Even here in the U.S., there can be some of that. It's not as difficult here in the U.S., but I definitely understand the struggle with that. So, very understanding.
Right. I also want to thank you for availing yourselves also, and thank you for participating and sharing your experiences with us. And I hope that we've learned from you, and I hope you've learned from us.
Yep, we have.
We've definitely learned a lot from you. As we've seen, the prevalence here is so much lower than in South Africa, and so the education and the understanding, or even just thinking about people with this condition, it doesn't come to mind as much. And since we don't have to face it as much, I think there's less knowledge or understanding on the condition over here. So it's great to hear more from you, and it was great having to search some of it for ourselves too, and how it's done here, how people are taken care of here.
I think just looking at it, it made me realize that the way HIV and AIDS is for you in South Africa is the way obesity, diabetes, and cardiac disease is for us over here, which I'm sure you guys don't see a lot of compared to how it is. So just imagine how HIV AIDS is your national issues. The national issues. That's how obesity and diabetes is here for us. So just seeing the differences, it was really
Can I also tell you that even what they call non-communicable diseases, which is diabetes and hypertension, it's also a problem in this country, right? Mm-hmm. Obesity is also a problem in this country. It's not only and can I also indicate to you that non-communicable diseases, that's your hypertension and diabetes and cardiac diseases, is also one of our burden of disease. Okay. So it's we are also facing a problem with diabetes and hypertension.
Oh, okay.
But it's just that with HIV, we're trying to prevent it from spreading.
Yes. It's.
We are trying to prevent it from spreading, but it doesn't mean that we are also not having a problem with diabetes and hypertension.
Yeah.
And incidentally, diabetes is if you look at diabetes, if you look at people that develop kidney diseases as a result of diabetes, and it becomes expensive to treat them. They have to go to a tertiary level hospital where they will have to receive dialysis, and it becomes quite costly to treat the diabetes, especially when it's complicated diabetes, where the blood sugar levels are not being normalized, maybe because of poor diet, because of our physical inactivity. So all those things are also one of our problems in this country. Diabetes and hypertension.
Okay.
So we don't differ that much in terms of specifically, there is a big difference in terms of our HIV prevalence.
Yeah.
Yeah.
Yeah, in terms of our HIV prevalence. And, excuse me, incidentally, our incidence of HIV in this country is being reduced a bit, right? In other words, new infections. So in a way that we are trying to manage new infections. However, because of the fact that we are, the country is diverse, it has these enormous problems.
Mm-hmm.
But the Department of Health or the government is doing all they can in order to reduce the prevalence, to reduce the incidence. That is why they're pulling all the stops to make sure that it does not spread. The disease does not spread. And that is why we're focusing on the young people, the people that are in high schools, those who are still very sexually active. That is where we are focusing on. To tell them that they need to be aware of HIV, they need to protect themselves from HIV, and all those things they get informed about them while they are in primary school. I don't know, in your country, what do you call primary school? Primary
They
school
call it middle school here.
Or elementary school, middle school, high school.
I know we call it primary school in Nigeria also.
I understand.
So that's why we're targeting that group. And we're also targeting those at high risk. Remember, I was showing the statistics for the sex workers. Those are the people at risk. Even there is an element of risk also with people that use needles, even in your own facility, where you when you are giving patients injections. We need to focus on you to make sure that you know how to because when you prick yourself, you know what to do. And also, we are making available those syringes that makes it difficult for you to prick yourself. In other words, a simple needle that it's like they call it a safety needle. It has a safety net. When you finish injecting, you just pull it back, and then it just covers the needle, so that you don't have to do anything to the needle after you've injected the patient. Okay, so there's a lot of things done as HIV prevention in this country. I hope that we can, in the US, you can share with us, and we can also share with you in terms of what we are doing for HIV. You have the resources. The United States, one of the richest countries in the world. You'd have the resources. I remember I showed you before that even this research that was done, it received funding from the United States.
Mm-hmm.
And the United States is assisting in this country in terms of providing the financing to certain programs which are aimed at HIV prevention. I know for a fact that there is an organization that is called Ubuntu. Ubuntu stands for humanity. They are assisting people, not only people living with HIV, they assist people with poor people with schooling. They provide education to young people. And those who are living with HIV, they link them to healthcare. I think they do have nurses also as part of the organization. Nurses, I think also one or two doctors that will assist. So there are those programs which are funded by the United States in this country.
Okay. That's very cool.
Right. Yeah. Okay. If there's nothing else, I think we are finished.
Yeah.
With our presentation. Once again, thank you so much.
Thank you.
Yes. Please convey my gratitude to Professor Hans also.
We will do, and
we will. And
please to Professor Bunt as well.
And Tolakele and lead the way. And I hope we still keep in touch after this.
Sure. Great. And then the recording, please, I think Professor Hans will pass it on to our lecturer so that she can look at it. Okay. And I would love to also send us a recording so that I can pass it on to Tolakele and Lindiwe. They can see what we talked about and discussed. All right.
Sounds good. Yeah, I'll ensure that they get sent to you.
Okay. Well, then on that note, I just wish to, well, in your country it's afternoon. Good afternoon. In my country it's evening. It's already dark outside.
Well, good evening.
Have a good evening.
Have a good evening. Bye.
Okay. Have a great weekend. Goodbye.
You too.
Bye.
Bye.
You too. So, stop recording.